So who are we talking to today, Tyler?
So today we are privileged to have our good friend, Eric Lee, doctor of chiropractic and medicine. He's been part of our group nearly since the beginning. You and Dr. Edwards have been friends for a long time.
Yes.
Give us a little background about your guys' relationship. I think it's kind of unique how you guys kind of came together.
You know, it's a good story and a fun story. I had a patient one time, and I was doing some graduate and fellowship training, and I knew there was a new neurosurgeon in town, and an orthopedic surgeon expressed to me, like, you got to meet this individual, and you're finding out the differences between a neurosurgeon and orthopedic spine, just the differences and stuff. And so I remember having a patient coming in, and she was adamant she did not want back surgery, and it was frightening. It's like her and her husband were very almost violent with me, but I said, listen, I want you to visit this neurosurgeon. And so I called and got an appointment with him, and the next day he saw her, and then like 2 days later surgery needed to be done.
Awesome.
Wow.
And it was very she needed it, and that started a relationship. But the really cool part about that is that we started talking a lot more about cases, and he had some questions about why some would order MRIs, chiropractors, and some wouldn't, just case management. And so that's the conversation that we started and how it got going more. So then, very shortly thereafter, we had a case come in from California, and this was a kid that broke his T3 and was pretty much a quadriplegic. He could barely move his hands, even though it was that lower, but definitely in a wheelchair. And another patient knew him from Temecula, saying, can you help? And I'm like, he has a T2 to T10 fusion. And how it got in was...
It's my own voice. That's a little distracting.
This is going to be really weird. But what happened is that they were in California, and no offense, but they wanted to fuse the bottoms down to L2. So my question was like, maybe, do we need to? So we started on this case. And I remember him talking, he was like, Dr. Edwards is like, what if we just fuse the segment that broke and remove the hardware? And like I said, that would be great, because I might be able to get onto the transverses and just see, if we can get this kid's arms to move a little bit, transport himself.
Yeah.
And that was the whole plan. So we did. And he went in there and he removed them. And I remember being in the OR witnessing this with him, which was really fun for me to see his work the first time, like the command of the OR, and I knew that very confident, just as you guys have seen many, many times, that he's so comfortable in there.
Yeah.
And patients don't see that part of it, but I'm like, that's a very good part of your treatment. And
it is kind of a shame people don't get to really see the back end of
know that part.
What happens in the OR.
But he removed it, didn't do any more fusion because it was fused, and we did our work afterwards a week later, and he went back to Temecula, and believe it or not, 2 weeks later the kid stood up with some support and can move his hands, and today he's an attorney, and he rides a bike and does everything.
Oh,
he still
cool.
Can't talk, but he can use his arms, and to see that story.
Yeah.
And I think that was the thing that kind of launched more conversation.
Yeah.
And then years go by, and then now we're working with you guys too.
Yeah,
so it's been fun. But yeah, that was the first interaction.
That's wild.
I've had a few patients that sound a little bit surprised when they're in a neurosurgeon's office and we're recommending that they go work with a chiropractor.
Yeah.
And we say, I think there's a lot that they can offer for you. I think this is a helpful service in the community.
Yeah.
But what's your experience being on the other side of that, with the chiropractic profession working tandem and together with a spine surgeon?
Such a great question, because I get people going, why are you recommending to a surgeon?
Yeah, yeah.
You know, like, wait, you're supposed to keep me from surgery and stuff. And like, and it's been fun to see that part too, but explaining to patients that there's a purpose for everything. But chiropractic is a treatment. And so what we've done in fellowship training, and we've all worked together, is spine management. Yeah. And that's more of a extra graduate training that we've done, really looking and analyzing and diagnosing root cause, ligament pathology, and so forth. They may need a surgery because there is a very highly compressed nerve, and I know the outcome. So my first 15 years of practice, it was like that, you know, don't refer out.
Yeah.
And now I know it the neurosurgical team can do, and the outcomes are going to be great. I know what I can do afterwards.
Yeah.
So that's evolved, which has evolved nationwide.
Yeah.
To where our residency program now and teaching that, and University of Pittsburgh, and there's a lot of different things happening with that. I think it just needs to come together. But I think people watch YouTube videos.
Yep.
You know, they always want to see some popping, which I'm not a fan of.
Yep.
And I've been pretty public about that.
I've seen some wild things.
Oh yeah, and
that's
you see
what's
wild people hammering in surgeries,
my goodness.
and you go, you know.
But that's not the common thing. You know, what's out on social media is typically just meant to be eye-catching. They want to just grab an audience, entertainment. Yeah.
But we get labeled with it because people will come in and say, "Hey, are you going to pull my head off?" You know, and I'm like, no, I'm not, you know.
I've seen that's how they killed somebody in a movie.
Yeah.
And then he was dead.
Those are some early on, ninja stuff. But so that's actually, it's a great question too, because I do have to tell people a lot. Explain it when I'm teaching about that relationship, and people are very curious. But as you know, I think the outcomes have been great.
Oh yeah,
for patients, and so when they do ask, it's not going down to get popped. It's going down to see, is there a biomechanical deficiency here for us to look at, and maybe not surgery now, but maybe later. But they might have a better outcome if we can. I'm
interested. What's your experience when you're recommending to a patient in our surgical practice to go see chiropractic care? How do you broach that conversation?
That's a good question. I think you get a feel for a patient's willing. I'm like, it's crazy. Don't do chiropractic. No. I try to come at them like a multidisciplinary approach mindset. So, if we're going to encompass physical therapy, we're going to, encompass pain management, being able to educate them about what chiropractic is and how it differentiates itself a little bit from those, the physical therapy sphere. I think both are very helpful in the spine management world. But I talk about the spinal biomechanics, the ligamentous pathology, something that I think you've been able to dive deep into. And I've learned a lot from you as far as knowing how to look at an x-ray and to acknowledge, how much ligamentous laxicity there might be. And so helping the patient, one, understand the purpose and goal of a chiropractor, and it's really looking at the whole ecosystem, right? I think sometimes we get tunnel vision and we think, oh, you got low back pain, let's just look at your lower back. But there may be problems upstream that are affecting your lower back.
Absolutely.
And so that's where I think chiropractic plays a crucial role in looking at the entire picture. And most of the time when I explain that to them, I think either they're going to buy in or they're not. And that's the same with physical therapy, pain management, all of it. But if you can educate them, you at least give yourself a chance to
Education's massive in this platform you guys have developed, and watching you this past year with getting to know other PAs and nurse practitioners, I think, and it's a different perspective. Right education is, I think, very vital. Because there is a lot of stuff out there, and people may say, well, what are we talking about? We're very evidence-based on looking at something with biomechanics, and our community with biomechanics has helped us a lot, with a lot of people around here just specializing in biomechanical ligamentous pathology and so forth, which is making more of an impact nationwide. We see it here because we're around it. I get to go lecture and see it from another perspective, Florida, Texas, New York, all these different places, and how they're gravitating, saying we really need to find that tissue problem, not just chase the pain. And once we can find, just like surgery, like you're fixing a structural tissue problem that is therefore causing this. But it might not be surgical, but there's still a structural tissue or something there that's not doing well, that's therefore
and we see it all through orthopedic care. It's talked about all the time in physical therapy. If somebody's hip or knee hurts, you're going to see somebody looking at their foot. The way that the foot strikes the ground changes the angle of the knee, which changes the forces on the hip. And it's a very well-known concept. And so now we're just trying to transition that into the spine. And I really like those terms of biomechanics and spine management. And I've been blown away every time I hear you and your colleagues as well talk about and evaluate an x-ray series of the spine and what's happening and where the imbalances are and the discrepancies. So I think people would be blown away at what these guys can provide.
Absolutely. And I remember when you and I went down to his office and he showed us the software that you're utilizing in order to evaluate, I don't know, with artificial intelligence, being able to accurately describe ligamentous movement and real true measurements. Is that correct?
Yeah. And if you think about the concept, that's an orthopedic concept that was studied, and there's so much data out on what happens to an injured capsule of the knee. There's tons of papers. I mean, as a trainer, you're past, there's a bazillion papers out there of how to rehab an ACL. Yep. So we have the data. Why haven't we applied it to facets? Yeah. It's a highly innervated capsule more than the knee. Yeah. But we can identify those little tiny things before they become a big problem. Yep. We want to put all the lug nuts on the tire so that when you drive out of there, the tire doesn't fall off. and so that's the concept where even fatty infiltration, stuff like that there's now devices for this. But we go, man, if we would have caught that upstream a little bit, maybe this wouldn't have had to occur. And the applications of other specialties have helped where we can now narrow that down into the spinal column.
I love it.
And I think that also, you play a huge role in the personal injury space in that respect. I can't count the number of times a motor vehicle accident cases come in, and there's really no identifiable injuries on the MRI, but they're in pain, they're hurt. The likelihood is that they suffered a whiplash injury. So how do we quantify that? How do we accurately describe and localize where the injury occurred to provide them that early treatment and intervention that they need?
I think we're obviously getting a lot better and better and better at it, and I think we're getting ahead of a lot of things, which I'm so happy why we're together as a team. But it is the number one thing that is always on the table when it comes to a med legal case, because it's obviously a little different than commercial insurance, because you have now another person trying to find injuries. How bad is it? Quantifying the injury, quantifying how much the cost is, future care, all these things that go in. And I think what's happened a lot in the past is somebody gets an injury and we want to treat like crazy because of that initial injury. And we kind of forget we need to kind of step back and go, what's really going on here and what other things are in effect. So when someone gets injured or doing something early on, they may have no pain, but they've had an injury and the body's compensated over time. And we take imaging and we look at it and we go, wow, they've got a really bad degenerative area, or we have some sort of thing that was not there prior to the accident, but it's going to be part of the equation, and we have to take that little bit into on their new injury. And so with this technology, we're narrowing that down a little bit better, and we're getting better and better. We have to change MRIs. We have to look at ligaments a little better. Imaging's getting better. They even have like 11 T's now.
11 T's. All the T's.
Yeah, it's a Tesla. I mean, which is people.
Why not make it a dozen?
Yeah, but in MRI world, 1.53 Tesla are pretty good out there, but they have 11 now, so which has been for research that can just basically see a bug on the moon, but
that's wild.
Sometimes you need to look at the bug. Sometimes we just got to know the moon's there. But if there's a really hard case, we're like, maybe the bug's on the other side of the moon. We can't find it right now.
We need 13 T's.
Yeah. If they make 24, we might be able to see the crater. With the bug in the crater. But
that's awesome.
The AI technology on that, but because from a surgical world, you can now see where, hey, that's going to be a problem, and now the technology in surgery's gotten better to where you might have to do a posterior fusion on that, a small one, before it becomes a large one, and that's cool stuff to look at.
I love it. I love it.
Eric, you're a good guy.
You're a man.
I'm glad you're our friend.
Dr. Eric Lee.
Thank you for having me on. I've lost sleep every night before I got up.
He had no idea he was going to be.
I know. We just
we sprung this on him.
That's what happens when you carry in the couches.
You show up, you sit down, and we talk.
Yeah. You guys are awesome.
Yep. And you might notice a little bit different backdrop for us. We're here up at Sundance Mountain Resort in Provo, Utah. We're here for the Summit Conference 2025. Brought to you by the Summit Medical Institute.
Yep.
If you don't know, you don't know. Go look it up. But we're looking forward to hearing from all the different speakers today. We're looking forward to all the different ways that we can collaborate and get together, just like we're doing right here.
Yeah.
I think there's a wealth of information that we can share back and forth. So we're looking forward to the weekend.
Nothing like it in the country. It's
That's
really
right.
cool.
That's right.
Yes.
All right, Eric.
All right.
Appreciate
Thanks,
it.
guys.
All right, man.
That was awesome. It was fun.